Afternoon, everybody. I'm Dr. Davaris, Chief of Laboratory Medicine at Grand River Hospital in St. Mary's General Hospital and the clinical lead for Cancer Care Ontario. On behalf of Cancer Care Ontario, the Canadian Partnership Against Cancer, and the Canadian Association of Pathologists, I'd like to welcome everyone to today's educational session on the gynecologic CAP cancer checklist. Before we introduce our speaker, we will get formally underway. I'd like to take care of a few housekeeping items. Firstly, today's presentation will be approximately 90 minutes in length and will include approximately 60 minutes of presentation time to be followed by 30 minutes of question and answer. Second, session is being recorded and will be made available to all participants via email links. The recording becomes available. Thirdly, the live presentation and the recorded presentations are eligible for CME credits upon completion and submission of evaluation form available electronically. Information for accessing the evaluation form was provided in the notice for the session previously distributed. Please note the CME certificates for each of the CAP checklist education sessions will only be issued for 1 month from the presentation date. The recorded sessions will remain available electronically for an undetermined period of time. CME certificates will only be issued for 1 month. Please refer to the session notice for the exact deadline date. Fourthly, please note that everyone's line has been automatically muted for today's presentation. Fifthly, due to the large number of participants, we are unable to troubleshoot any WebEx connectivity issues as part of this call. If you're having difficulties accessing the WebEx portion of this teleconference, please call WebEx support line 1-866-29-3239. I'll repeat that number again, 1-866-29-3239. Secondly, we encourage you to submit questions at any time during the presentation using the chat feature. For instructions on how to use the WebEx chat window, please refer to the documentation previously distributed. The last item is during the question and answer portion of the presentation, in order to avoid question collisions, I pose the submitted questions on your behalf as long as time permits and the order in which they appear. In the window, please include the following information: institution's name, name of the individual posing the question, and your question. So it is my distinct pleasure to introduce Dr. Bill Chapman. Chapman is currently Chief of Pathology and Medical Director of Laboratories at St. Joseph's Health Centre in Toronto. He has a subspecialty interest in gynecologic oncologic pathology. Prior to coming to St. Joseph's in 2007, he worked as a gynecologic pathologist at University Health Network and Princess Margaret Hospital for about 15 years in Toronto. Bill has a special interest in cervical cancer and its precursor lesions and in the role of HPV testing in cervical cancer screening. He is currently a member of the Ontario Cervical Cancer Screening Clinical Advisory Committee. Although he is now working in a more generalist community pathology setting, he was, when at University Health Network, working in a pure subspecialty practice and was involved in collaborative research and teaching. He is an author of about 70 peer-reviewed publications in the area of gynecologic oncology. At the University of Toronto, Bill has been very involved in many aspects of education and educational administration. He is a professor in the Department of Laboratory Medicine and Pathology at the University of Toronto, with a appointment in the Department of Obstetrics and Gynecology. Bill's residency training and early practice years were at Western University of London in Ontario. He was interested in gynecologic pathology at Western under the mentorship of Dr. Mary Ellen Kirk. For residency, he completed a fellowship training in gynecologic pathology with Dr. Bob Curran, a well-known and respected gynecologic pathologist who at that time was based at Georgetown University in Washington, D.C. Without further ado, I introduce Dr. Bill Chapman to today's talk on the gynecologic CAP cancer checklist. Bill?
Thank you much, Demo, and thank you to Cancer Ontario for inviting me to give this talk. My first slide really outlines the emphasis that I will be giving today. In fact, it's a little bit of a lie there, because in fact I've decided that I won't speak at all on vagina. It's extremely uncommon, and that there are enough interesting and important things regarding cervix and vulva that I would cover. The minute, I'm having a slide advance problem. It wasn't a few minutes ago. So the outline that I'm going to follow is that for the two topics I'm going to cover, I'm going to go over some context, basically where these tumors in the great scheme of things, they're frequently there, where we see them as pathologists, some of the clinical aspects that relate to the pathology, then to get into some more details about some of the important pathological aspects of it, and then to cover some aspects of the checklist. With both cervix and vulva, there's actually some things that I think that are really important in their diagnosis that are probably not related specifically to the checklist. So I'll probably actually cover more that's on aspects of the pathology not specifically related to the checklist. So we'll start with cervix, beginning with some of the context as it relates to cervix. There's really 5 main points I'd like to emphasize. The first one being the way that cervical cancer presents, followed by something on where pathologists encounter cervical cancer, the histology, the pathological correlation, and then after the initial diagnosis, what subsequent issues might we see on which we need to provide information. The first point on presentation is I think that this is really an important point, that patients with cervical cancer present in one of 2 major ways. One is that they are symptomatic with invasive cervical cancer, presenting with something such as bleeding, will have a mass found on physical examination. This is one way of presenting. The other group of patients will be seen without symptoms, but will be encountered in the colposcopy clinic through screening and will be found to have invasive cervical cancer. Some of these will actually be, will have mass identified even though they were asymptomatic, but others will be completely subclinical and not have either mass or symptoms, but will have invasive cervical carcinoma. But that latter group will present more like they have just high-grade squamous intraepithelial lesions, and that's important to recognize for reasons that I'll elaborate on shortly. The next point is that with either of these presentations, what we're going to see as pathologists are going to be cervical biopsies. And it's also important to recognize that this first encounter, this is happening anywhere there are gynecologists or people practicing colposcopy, and not necessarily at major cancer centers. The point relates really to the extent of the histology that we will see. Largely, we will be dealing with squamous and glandular lesions. And the important distinctions that we will need to make for the squamous lesions, we'll need to know when we see these biopsies if we're dealing with an epithelial lesion or if it's invasive. And if it's invasive, if it fits into a superficially invasive squamous cell carcinoma category, which is what that abbreviation that you see there is. Glandular lesions, they do not have the intermediate category of the superficially invasive, but there can be certainly a very challenging distinction between adenocarcinoma in situ and invasive adenocarcinoma. Less commonly, we will encounter some other histologies. These other histologies tend to not, or I would say do not, have a recognized precursor category, so will be seen as usually fairly advanced invasive cancer. Adenosquamous, which encompasses an important category of small cell, as well as, of glassy cell, and the other is the small cell neuroendocrine, which I'll elaborate on a little bit later. I'm not sure if I do anything with this. Okay. The next point, really an important one as it relates to the clinical pathological correlation, which is that those with a mass, whether it's the symptomatic mass or even the asymptomatic one found incidentally, these will be invasive cancer and not superficially invasive. Those that have no symptoms and no mass, some might turn out to be cancer, but the vast majority of those patients coming through a colposcopy clinic will have SIL. But we will pick up a few invasive, both superficial and, more frankly, invasive cancer, but usually of small volume in that group. But these points are important in helping us sort out biopsies. Biopsy will be the initial starting point for us. But invasive carcinoma has been confirmed. There are a fair number of patients who will have no further specimens. Those with large, bulky disease, obviously invasive, and therefore it's important that we make the appropriate diagnosis on that biopsy material that we have. Those who can be do qualify for surgery. Those that are frankly invasive may go on directly to a radical treatment, radical hysterectomy or trachelectomy, and in those cases, the diagnosis has been done. Now it's mostly about staging. There will also be a fair number of patients that will go from initial biopsy to an intermediate Leep or cone specimen, which will be largely to try and assess whether or not a patient has a superficially invasive or frankly invasive disease and need a radical procedure or not following. But these leaps and cones are often where a great deal of the challenge is in the diagnosis of cervical cancer. So basically with this context in the background, I'd like to go on to talk more about some of the specific challenges facing pathologists. And I divide this up by talking first about the diagnostic biopsy, then about the Leep and cone, and then finally the hysterectomies, the radical hysterectomy or radical trachelectomy, and the exenteration specimens, which are the ones for which the checklist is actually designed for, but actually I will probably spend considerably more time on a couple of the issues on the diagnostic biopsy and Leep and cone. Before getting to specific histology in the diagnostic biopsy, I go again to this issue of history being important, because it's a very good starting point. If you know at the outset that a biopsy that you have is from a patient with symptoms and a mass, you're not going to make a diagnosis of SIL. You are not going to make a diagnosis of a superficially invasive squamous cell carcinoma. By definition, a superficially invasive squamous cell carcinoma cannot be grossly evident. So it's going to be, if there's a squamous lesion present or a glandular lesion present, if it has the symptoms, it should be invasive. Look at things from the other way is also important. Most patients going through a colposcopy clinic that are asymptomatic, and particularly further defining those as ones that don't have a mass identified at all, the vast majority of them are going to be SIL, so we shouldn't be looking for cancer in cervical biopsies from the colpo clinic, but there will be some that will come through along the way. We'll look specifically at squamous lesions, and the things that really are most important is first of all to differentiate invasion of any kind from a squamous intraepithelial lesion. So these, whether or not these are coming from patients with symptoms or not, we're dealing with small amounts of material, and we need to have the criteria there for invasive carcinoma and to ensure that it's not just an intraepithelial lesion. It's also very important that that be stated in the biopsy report, even if you're saying that you're not sure. That's better than saying something to the effect of squamous cell carcinoma and then later somebody wondering why there wasn't a major lesion, and you say, well, I never said that it really was invasive squamous cell carcinoma. That's not appropriate. You really have to state whether or not there's invasion. And since we don't use the term squamous cell carcinoma for pre-invasive lesions, anyhow, that's kind of a moot point. But it is important that invasion be stated even if the statement is indeterminate. If invasion is present, I'm not going to make a diagnosis of superficially invasive squamous cell carcinoma on a biopsy because you need a full excision to really see that everything can satisfy those criteria. But you can say on the biopsy that you have already satisfied the criteria for frankly invasive disease. The more precise definition of superficial invasion will come along in just a minute or two, but until then, I just want to make the point that on the biopsy, you not make that diagnosis, but you can at least say that it's definitely more than that and it's been exceeded on a biopsy. Looking a little bit more specifically at some of the histologic clues to the diagnosis of invasion, again, I emphasize the history as being very important, and particularly when you have the history of a symptomatic patient with a mass, and it's the biopsy of that mass. To invasion, the eosinophilic change that I'll show examples of shortly, where the cells become bigger and take on ample eosinophilic cytoplasm, is certainly one of the major and most useful criteria. The next point, I'll actually skip to the 2 down to extent greater than can be explained by extension into crypts or tangential sections, because that's probably the second most important in making the distinction between non-invasive and invasive. Irregular growth patterns, yes. Nucleoli typically are not seen in SIL, so that may be useful, but it's hard to make all of your judgments based on that alone. So here, for example, you can see the down in the this area here, if you can see the pointer that I'm activating with my mouse, the little focus of an eosinophilic bud of cells coming off an intraepithelial lesion, and higher magnification showing that. So nice example of that way of diagnosing invasion. And go back to a somewhat lower magnification, you can see a tongue here emanating from an area of intraepithelial neoplasia. Higher magnification of the same case. Here again, this is getting a little bit more complex, but I show it mainly because it's showing nicely the contrast between the very eosinophilic nests and the much more basaloid-looking high-grade SIL. Here now, we're getting to a point where it's not just eosinophilia. You're just seeing too much disease in an area that can't really be explained by the extent of where the glands are and what you might see due to tangential sectioning. So it's essentially, this is kind of what I consider the second point at diagnosing invasion of the eosinophilia. Here's a somewhat much more confluent looking mass, fairly superficial, fairly focal, but difficult to explain this by tangential sectioning. Another superficial area that you can see almost totally confluent, finding something that really is quite difficult to explain by any other mechanism than true invasion. And that's getting into things that are clearly much more obvious, but it's really kind of the what the earlier ones were working up to. The main criteria for diagnosing invasion, there are some softer ones. One that I'd like to point out, stromal changes are in fact quite difficult in cervix. The stroma in cervix is often very inflamed. I mentioned keratinization and papillomatous growth. You can have keratinizing SIL. You can have warty-looking SIL, but those growth patterns are more commonly associated with invasive cancer than they are with intraepithelial lesions, and therefore they're more relative. You wouldn't want to make the diagnosis on the basis of those alone. One aspect that's very important is looking into a kind of subtype of squamous cell carcinoma, which is the one that is called the papillary of transitional cell type of squamous cell carcinoma of the cervix, which is noteworthy because when you see that, you know that it's almost always associated with invasion, but that the invasion not be able to be easily established on biopsy. My own practice is typically to make a statement saying, oh, invasion cannot be identified. This histology is generally associated with invasion, and it's this sort of thing that you are seeing on biopsy that are typical of this particular type of lesion. Another point that I wanted to make about squamous is one relating to small cells. Cell carcinoma, neuroendocrine, is uncommon, but I think it's important just to understand that historically there's to be a category of small cell squamous cell carcinoma. So just the importance of being very clear when you say, you use the term small cell in carcinoma of the cervix, that you identify which of those you were talking about. And for the most part, we would tend not to use the terminology small cell for squamous lesions anymore, but this is an obvious squamous lesion with some smaller cells, as opposed to a true neuroendocrine, which are less common. A couple of more points about squamous lesions diagnosed on biopsy is very all cases you should make a comment as to whether or not there is lymphovascular invasion. Whether it's present or not, always make the comment. For example, most cases it's not going to be, but clinicians are still expecting a negative for lymphovascular invasion in the report. The grading is not of great importance in squamous lesions, period, and it's not important substantially certainly in the biopsies, but it's certainly if grade is put in, that's no problem. So moving on then to the adenocarcinomas. The adenocarcinomas are biopsy. The big task is going to be, is this an invasive or an in situ lesion? Again, you need to state this in the report. So it's not acceptable to say adenocarcinoma without a comment somewhere saying either it is invasive, it's not invasive, or I'm uncertain as to whether it's invasive. There is no recognized superficially invasive category for adenocarcinoma in situ, but it is nevertheless a very challenging group of biopsies to look at often, just in differentiating invasion from non-invasion. So the clues that are out there for us, probably the best one is really loss of lobular configuration, short of something that's obviously extensively invasive. But in adenocarcinoma in situ, the glands can become somewhat complex and branching, but the loss of lobular configuration is what you want to see to call it cancer. And that's the most useful criteria because single cell type invasion is not often seen, and again, stromal changes are often not helpful. So here, starting at a very early pre-invasive lesion, you can see the dark adenocarcinoma in situ, maintaining a very much the orientation of the glands, and still not much deviation from the normal architecture of the glands, but you can start to get this, and it's still adenocarcinoma in situ, where you were seeing complex branching, but maintaining a lobular configuration, or better demonstrated here on this next slide. So that's as opposed to the more irregular invasion, not conforming to any nice lobulation. Now, one other thing with adenocarcinomas is that every time a pathologist sees something that they're going to call adenocarcinoma on a cervical biopsy, they should always think about the possibility of endometrial adenocarcinoma. And the things that you would want to think about first are history. Just a younger woman whose presentation is more that of postcoital spotting rather than postmenopausal bleeding. More importantly, is some knowledge about the tumor site. If you know that from the clinician or from imaging, that the bulk of the tumor is in the uterus, in the corpus, and involving the cervix, that is much more likely to be an endometrial primary, because cervical cancers rarely extend up into the corpus in a significant way. The histology, if you find a precursor lesion that's useful, adenocarcinoma or some evidence of adenocarcinoma in situ, I should say, of the cervix, or hyperplasia of endometrium, if you see that in the specimen. The histology, I think certainly most adenocarcinomas, you want to have this thought process, but if it's really endometrioid look, and cervical adenocarcinomas tend not to have that real endometrioid look, even though there is a category of endometrioid carcinomas of the cervix. So if it looks like a cervical cancer, it's worth thinking about. And the immunohistochemistry that's useful, Vimentin positive in endometrium, CEA negative in endometrium, positive in cervix, ER positive in endometrium, not in cervix, and you don't need to do both ER and PR. The literature is basically just on estrogen receptor, and P16 should be positive in cervical adenocarcinomas and negative in endometrioid type of endometrial adenocarcinomas. And so very endometrioid looking tumor in the cervix. And you see here it's a Vimentin because you can see the stroma staining, also the epithelial cells staining, and this is estrogen receptor. So an important consideration. You have a biopsy for adenocarcinoma. Like other cervical cancers, like squamous, you do want to comment on lymphovascular invasion. And again, the histologic subtyping is not really very important in adenocarcinomas of the cervix. Some other histology that you might see in biopsy would include adenosquamous carcinomas of the cervix. These tend to be differentiated. They don't have a precursor. They're likely to be rather bulky. So since they won't have a precursor, really it's going to be cancer and just deciding if it fits into this histologic type. Glassy cell carcinomas are subclassified or a subclassification of adenosquamous. One of the important things about glassy cell, these occur in young women. They're usually very exophytic mass, and there's some evidence out there, and some practices follow a feeling that you have that diagnosis that urgent radiation therapy is needed if these patients are to be cured, and that they will prioritize those. Even though it's a bit uncommon, it is useful to diagnose for these reasons. And it never really is quite as straightforward as it might seem in the textbooks. Now, here's an example of adenosquamous carcinoma, which is rather typical of those in the cervix. They're more poorly differentiated and look kind of like sheets of squamous with kind of punched out glandular lumina, as opposed to this is the more endometrial type of adenocarcinoma with squamous differentiation, where you see you don't get this as primary cervix. Its adenosquamous is generally a poorly differentiated lesion. And the glassy cell will be highlighted to that with the sheets of these pale cells with big nuclei, prominent nucleoli, usually at least some areas with fairly distinct cell borders. But I think I can say that it's not so straightforward a diagnosis as that I would ever feel very comfortable about it unless I hear this history that it's a young woman who has a large exophytic mass of this sort of ill. So I'll go on now and talk just a bit about some of the issues with cervix on the Leep specimen. And this is only going to be a couple of things in addition to what we've already talked about. First of all, I would say that there is a CAP checklist for Leep and cone specimens. It's not required by Cancer Care Ontario, but it's probably a good idea nonetheless. There will be many patients that this will be their last specimen that has invasive cancer in it, some of the small volume disease. And in squamous lesions that do go on to have a cone because they have small volume disease, it's mostly about trying to determine if it's a superficially invasive lesion or not. The recent CAP guidelines that have come out have indicated that a pathologist should actually make on a cone specimen the diagnosis. They should state dimensions and actually qualifying whether they feel that those dimensions satisfy the criteria for superficially invasive or do not, which I will get to shortly. And then a very important point is that superficially invasive squamous cell carcinoma is not, it actually includes the fact that it is not grossly visible. The recent CAP guidelines that I was mentioning are, this is the publication from Archives of Pathology and Lab Medicine that came out very recently. One Canadian among that group, Terry Colgan, and there is now a Canadian group working up the same guidelines for our setting. We are dealing with a Leep or cone specimen and trying to make the distinction as to whether this is truly invasive or if it's superficially invasive. Before I get down to the measurements, I'm going to say that the main thing is that the superficially invasive tends to be multifocal tongues that are easily separated. Frankly invasive tends to be unifocal, tends to form a mass lesion, or at least, even if it's somewhat tongue-like, that are at least very congregated together. So that's one of the first things that you can do to try and make as much sense as you can out of before you actually get to the actual dimensions. The dimensions being a depth of 3 millimeters from the basement membrane and a horizontal extent of 7 millimeters less. And basically these definitions are based on the horizontal dimensions on a single slide. And most of the time this is not going to be too much of a problem. You have a number of the little tongues. You take their width, which is all going to be minimal, and add them together, and you'll hardly ever come anywhere near 7 millimeters, particularly if your depth is clearly well below 3 millimeters. And if something meets the criteria for superficial invasion in 2 dimensions, it's probably not going to exceed those in a third. But the problem is going to be, in some of the cases, that they do start to get a little bit more confluent, and you start to have a lot more foci. And it really think this paper here this is something in a way that actually makes a lot of sense when you start to think about it. And what they're saying here is that the top panel, that you take the measurement of the width and add them all together of little invasive tongues as long as you can see their attachment to the overlying epithelium. In the bottom panel, what they're saying with the ones listed as 2 is that if you have any that are detached, you take the whole width of all the tongues that you've got in that field. And that may not sound very scientific, but in fact it's really quite relevant, because what it's starting to do is starting to actually identify lesions that are where the carcinoma is more aggregated together and forming almost a single mass. So some real examples, this sort of thing, tongue, you can measure the width of that. Tongues, here more individual little things coming out that are going to be less than 3 millimeters, but you clearly measure the whole width of this. You're starting to get into something clearly more approximating a mass, even if it's not grossly apparent. Another one with a mass with a telltale little lymphovascular invasion down below. That's really most of what I wanted to say about the Leep and cone. Again, emphasizing that we do mention lymphovascular invasion, presence or absence, but importantly, the current definition, and the one that we agreed upon in that paper that I mentioned earlier, the CAP one, is that lymphovascular invasion is not part of the definition. So you can still call something superficially invasive with lymphovascular invasion, but it's not part of the definition, but you're still going to report it. Margins should be reported, and you will report margins both for whatever invasion you have and whatever intraepithelial lesions that you have. Just an example of an involved margin with which looks like pretty obviously, frankly, invasive cancer. Here's one where you can see margin involved by something that is just up at the tip, and it is looking like it could be fairly substantial, but it doesn't satisfy the criteria for calling it superficially invasive, even though it's less than 3 millimeters in depth and less than 7 millimeters wide, but it involves a margin, and that is another one of the major criteria in the definition. So 7 millimeters wide, less than that, less than 3 millimeters deep, and not gross mass, and margins must be negative. Adenocarcinomas of the cervix, when you're looking at a Leep and cone specimen, I think about the only thing to really add from what I said in the earlier discussions on adenocarcinoma is here your main issue is invasion versus adenocarcinoma. I think at this point I just decided I'd bring up 2 other subtypes that you might see. You might also see these in the biopsies, but the well-differentiated viloglandular one is an important one because the Leep may be the last specimen. Deviation adenocarcinoma is important because it may be deceptive. With regards to the first, a very different type of histology. If you see that, a cone may be sufficient, so you will want to make that diagnosis. Higher magnification, an example of a minimal deviation, which I think shows the thing that these are usually fairly obviously malignant, at least in their pattern of growth, even if they're deceptive in their actual histology. Even cone specimens, the other tumor types that I mentioned, you're much less likely to see adenosquamous small cell. You might, but these are usually so bulky at the time of presentation that they often go direct to chemoradiation or to to that, even without a radical procedure. One point I just wanted to make: simple hysterectomy, not likely to see these except in surprise situations. I mention that because since the checklist does indicate that the simple hysterectomy, or that it is a checklist for hysterectomy specimens, but of course will mostly be radical hysterectomies, but occasionally a simple hysterectomy will unexpectedly have invasive cancer in which case you would put that in the checklist, even though it's not really made for that. Going on to the radical procedures, first of all, I just wanted to make the point that a radical hysterectomy differs from a simple in the presence of a large amount of parametrial tissue going out towards the pelvic sidewall and a vaginal cuff. A radical trachelectomy, which is done more frequently in young women wanting to preserve childbearing, is essentially a radical procedure that amputates the cervix with parametria and vaginal cuff. The PIC exenteration, which is listed in the checklist, is a surgical procedure aimed at cure that, in my experience, has usually been done after a failure of chemoradiation. These are uncommon and just involve radical hysterectomy along with either bladder or rectum or both. The pathologist's role in these are really more about staging and extent, and these are actually a lot less challenging in many ways than the decisions that have to be made on the biopsies and cones. Of the pathology issues in these radical procedures, I did want to point one thing. It's very important to get, when you have gross tumor, that described as well as possible, particularly its size, how far through the wall it goes, parametrial involvement, and vaginal involvement, because extending to the vagina is part of staging. That's going to be very difficult histologically, because going from the exocervix to the vagina, it's so very important for it to be mentioned in the gross if there appears to be extension into the vagina. The margins in the radical procedures, in the radical hysterectomy, the vaginal cuff and the parametrial edges will be the margins you submit. The radical trachelectomies will also include those, but also the amputation point with the lower uterine segment. That is often usually done, certainly in the trauma centers, frozen section. Just before getting to that, this was just a gross photograph just to show again that the need, if there is something visible, those gross dimensions will be important. This is an example of the radical trachelectomy, a fairly recent article by colleagues from Sunnybrook Hospital describing the intraoperative assessment of these, the margins in these. And here you can see from their paper the amputated bit of cervix with the parametrial tissue around it, and then just flipping it up, that's the cervix. You can see the vaginal cuff tissue come away from that. But in these, the margin that is going to be done for frozen section is the amputation point with the lower uterine segment, which will be more or less coned at frozen section, and the physicians will go back and revise if that is positive. So that really kind of gets through the role of the pathologist, and now to the checklist part. It was actually, the part vulva is short. I was hoping to be at that at about this time, so maybe a couple of minutes behind. I'll try and go through the aspects of the checklist. I think we've actually covered most of the relevant things, but I just wanted to bring up a couple of things related to the checklist. And actually, I pluralize it here because I will say just a word or two about the Leep and cone checklist. But some of the issues that we want to look at in the radical hysterectomy, trachelectomy checklist relate to size, site, histology, the histologic type grade, the margins and stage, and then a couple of the aspects of what is differently in the Leep cone checklist. So this is a checklist that is for all carcinomas of the cervix, all invasive carcinomas, so that would include the superficially invasive. The specimen stuff is fairly straightforward. Tumor size, this is a checklist that is for these radical procedures. I should just clarify, I said a minute ago, it's for all invasive carcinomas, but the trolectomy, hysterectomy, exenteration checklist will be primarily, should be, you're not going to get superficially invasive disease in those. This should be frankly invasive disease, so you will want tumor dimensions. And certainly if there's gross tumor there, which there usually will be, but a fair number of the radical hysterectomies have, if they were low bulk, low volume disease, they may have been completely excised in the cone, but where possible, if you have gross disease, you would put in the gross measurements, certainly where there is bulk disease. Now, as far as the tumor site is concerned, it was previously optional, now mandatory, to identify the specific quadrant in which tumor is present. This is actually corrected from the previous, and actually if you look at the previous, which has been deprecated, you can see that the tumor site there says right superior quadrant 12 to 3. Go back to the current right superior quadrant is 9 to 12, and 12 to 3 is left superior. So the initial, the earlier checklist had made an error in the o'clocks as opposed to the quadrants. The quadrant right superior being as seen from the patient's perspective, the clock being from the physician's perspective, and so that needed to be corrected, and so therefore was deprecated. And since deprecate means to express earnest disapproval of, we have disapproved of that, and now we have the correct version, and the correct version is now mandatory. The mandatory aspect of it, I think it's less important as to what o'clock it is, or whether it's right or left. It's more about the fact that it can be seen in multiple quadrants. But there's no clinical decision that's going to be made related to the fact that it's in one quadrant versus another quadrant. So, as was asked a number of years ago by Chicago, moving then to the histologic types, identifying tumors as squamous cell and adenocarcinoma or the other histologic types is important. The other information in there is probably less relevant. Even though it's mandatory to differentiate mucinous from endometrioid of adenocarcinoma, that's probably not awfully important. If you see something that's very endometrioid, I think the most important question is to say, is it really an endometrial adenocarcinoma or not? You can see that that's a fairly limited listing, and unlike many other checklists that have many items, the checklist for cervix is less, but the totality of what can be there can be found in the explanatory notes. But the authors of the checklist have chosen just to put the two main ones, squamous, adeno, and then all others as other. Thing is never been shown to be of huge relevance in the cervix. We will apply it. Perhaps a little bit more relevant in glandular than in squamous carcinoma. When it's that relevant, then there's also not various rigorous criteria on how to do it. Most of the squamous will be moderately differentiated. Margins that we already talked about, and so I don't think I need to elaborate any further on that. lymphatic invasion needs to be noted. One of the things about staging, well, there's two things. The first one is that you can see that what's now PTA1, the stromal invasion less than 3 and less than horizontal, that is exactly synonymous with the recent guidelines have also come up with as the definition of superficially invasive squamous cell carcinoma of the cervix. Going on to the more advanced stage, one of the things that's interesting about the cervix protocol is that unlike many of the other protocols that we deal with, most of the extent that relates to stage is also addressed independently. Here, you'd expect that there might be, if it was following the same format as other checklists, that there would be something saying involvement of parametrium, involvement of cervix. I'm sorry, not involvement of cervix, involvement of vaginal cuff. But this checklist has chosen to essentially not include that, and I know that some institutions have chosen to add it, to separate statements related to that, but this checklist, the authors of this have chosen just to put it into the staging, and the staging should cover most of those questions. I personally have always liked to put in a statement that in addition to identifying the stage, saying how much of the wall thickness is involved, how close it is to the parametrium, whether it's into the parametrium, and whether or not it extends into the cervix. But certainly all the information is nonetheless covered in this approach that they're using. Nodes is fairly straightforward, except to note that most nodes are pelvic that you see in cervical cancer resections. Occasionally para-aortic nodes are submitted. When para-aortic nodes are submitted, they're actually classed as distant metastases, so maybe one of the few situations where you might actually get to fill in a PM1 rather than not applicable. The things that differ in that I just wanted to point out from the cone Leep checklist, two things to note. Tumor size. When you think about it, most of what you're going to be seeing in a Leep cone is going to be either small volume invasive or superficially invasive. So they've amended a little bit for that. For the invasive, the 3 dimensions necessary to put in. But then second component here, there's also asking to include the depth in and horizontal extent for those cases that will be superficially invasive. And regardless of which of those 2 categories you're dealing with, you are actually required to complete both as best you can. Margins actually are more explicit about margins in the cone protocol than they are in the hysterectomy one. But essentially, you want to identify if you have invasive or intraepithelial lesions at endocervical margin, exocervical margin, or the deep stromal margin. And this is just a picture I tossed in showing the cautery effect in an adenocarcinoma in situ. And even though there's a fair bit of cautery, I think you can still say that there's adenocarcinoma in situ at that margin. That takes us to the end of cervix, and so I'm thinking about 10 minutes before I wanted to be. So I'll continue on then with what I'm going to say about vulva, and the first, I'm going to structure it really in the very same way that I did cervix. So in the context, we're going to really deal with the same issues. Number 4, the 2 categories being the equivalent of the clinical pathological category that I had in cervix. And so as far as the presentation is concerned and our points of context, virtually all patients with vulvar cancer will present with symptoms. Itching, burning, lesion will generally be present. It may be there's some bleeding of it. But the differential here is even pre-invasive lesions, not to mention some inflammatory lesions, can present with similar symptoms. So even the pre-invasive lesions at vulva will be symptomatic. Pathologists will encounter these through biopsy, so it'll be the same. A patient will present, we'll see the biopsy, and we'll have to decide which category it fits into, invasive, pre-invasive, or perhaps none of the above. The histology, for all practical purposes, you're dealing with squamous cell carcinomas, but there is, as I've mentioned, a differential diagnosis that really can include a kind of a reactive squamous hyperplasia, as you might see in patients with lichen sclerosis. Even though the lichen sclerosis is quite distinctive, they often have associated areas of hyperplasia associated with that, and differentiating intraepithelial neoplasias from invasive squamous cell carcinoma, and is again in vulva a superficially invasive squamous cell carcinoma category. It's defined differently than that for cervix. It's only 1 millimeter in depth, and rather than measuring from the closest basement membrane, you measure from the tip of the superficial point of an adjacent dermal papilla. So that's a pretty small amount of invasion to get. There's lateral dimension taken into consideration, but with the 1 millimeter measuring up from the top, there's not a lot of cancers that will be that superficially invasive. So this is, relatively speaking, uncommon, certainly relatively less common than superficial invasive for the cervix. Now, as far as the clinical pathological correlation, we recognized for many years that there are really two categories, and this is still valid. There are young women who present with with a background of VIN, similar to the type of VIN that's seen in the cervix, or the CIN that's seen in the cervix, associated with HPV, but very distinct from that, a group that occurs in older women with a history of chronic inflammation and often with a background of lichen sclerosis. A little bit of elaboration on these. The HPV group that go through VIN before they become invasive are actually the least likely ones that you'll see as clinically relevant invasive cancer. These are much slower in their progression than cervix is, and very few of the VIN cases, even if left untreated, progress to cancer. Most of the important cancer are the ones that are of the chronic inflammation group, often associated with lichen sclerosis. And they are associated with a type of VIN that has been called differentiated VIN or VIN simplex, which I will be, I think, probably the one main point that I still have to go. Once biopsy has been done and the diagnosis of invasive carcinoma is either suspected or made, there will be excisions that will follow, but it is really probably more the biopsy where the pathologist will be challenged. So again, I think that we're, with the things that we're talking about here, that the challenging areas are going to be the ones that are not just going to be restricted to the big cancer centers. So as we have talked about the presentation, we can now talk about the role of the pathologist and the things in diagnostic biopsy. Again, you want to do the same thing you would do in cervix. If you can exceed the criteria for superficially invasive on the biopsy, you say so. You don't leave it open if there's no possibility it is superficially invasive. Again, always make a statement regarding lymphovascular invasion. If the biopsy that you're looking for is one that has the classic type of VIN, and you're looking at that, you see, could this be invasive cancer? It's quite unlikely that it will be, to start with. Odds are that it won't be, and there are traps that you can fall into. VIN can extend along hair shafts, just in the same way that CIN extends along endocervical glands. But the criteria for invasion are going to be similar to those in the cervix. And the superficially invasive category, which I've already said is not very likely, but if it's going to occur, it's going to occur in this category, associated with the classic HPV type of VIN. But this is not where the bulk of your clinically significant invasive cancers are going to be. So here you see a classic VIN with some involvement of a hair shaft, but not likely to see invasive cancer here. Some of the cases that I have seen have actually been in immunosuppressed persons, which I think is probably also an important point. But the ones where you're going to see most of the invasive cancer are the older women. There's going to be a background of hyperplasia and chronic inflammation, maybe lichen sclerosis. These can be very deceptive because the carcinomas are, although aggressive, quite well differentiated. But the association that this has is with what has been called differentiated VIN or VIN simplex. But the important thing to know about that is that this is called VIN because you can't find an invasive component, but it's mostly associated with invasive carcinoma. It's not a long-standing precursor. Relevance then is if you see that on a biopsy, you alert one to the presence of, to the possible or likely presence of invasive carcinoma, even if you can't make it. So it really is the differentiated VIN and the carcinomas associated with that cause some of the greatest challenges. This is an odd thing where you really have hyperplastic epithelium with some tibia within completely differentiating epithelium. It can be very difficult, very subjective. One of the things that has come up in recent years that is quite helpful, adds a little bit of objectivity to it, is that P53 positivity can help to distinguish these from a non-neoplastic hyperplasia. Lichen sclerosis is often associated with these. It is not considered a precursor, but like other things have an association with invasion developing in that setting. So it's important to identify it from that point of view. So here we see a hyperplastic epithelium. You can see a 3D peg that has some form of more samoid-looking differentiation within it, and you see these areas that are developing these atypical cells. You can see prominent nucleoli there, often showing this sort of pattern of these larger cells, but without invasion. There are other examples, but this is obviously fairly subjective. But if you see things along this line, probably good to do a P53 and alert to the possibility of there being invasion, which there usually is. Here, a larger excision. There you see something that you could call differentiated VIN. Here, little foci of invasion. If you're not quite convinced by those, here's what is seen a little bit elsewhere. So very important to be able to identify those changes, as subjective as they might be, and this is the tumor type to identify. Most cases will probably have clinical symptoms that would be highly suspicious as well. And then just showing the associated lichen sclerosis, which may be present. I did just mention for completeness Paget's disease, just to say that patients with similar symptoms may have Paget's disease. I don't think it's usually too much of a diagnostic issue. When the incision is done for vulvar cancer, the main thing is going to be you'll usually have made the diagnosis on the biopsy. The excision will certainly get the full extent of it. Unlikely, but you might have to confirm a superficially invasive case on excision. But as I said before, these are less common. So I just wanted to finish up with some things about the Vulvar checklist. Protocol applying to all invasive carcinomas on excisions, and their distinction here of excisional biopsy and vulvectomy is really what anything that is the excisional procedure, whether it actually has we don't see complete vulvectomies very frequently any longer, but generally excisions, sometimes with some recognizable vulvar structures if they have to sacrifice clitoris, for example. But it's really about the excision specimen. And I think that the most of the points on it are fairly straightforward. Sentinel lymph nodes are being done with greater frequency. I also could have mentioned that sentinel lymph nodes are being done with increased frequency in cervical cancer, but perhaps at this point more a part of general practice with vulva. The points to note as far as the dimensions are concerned, I think going down to the tumor size. There's one little peculiarity about vulva that is perhaps a little vexing, but it's pretty easy to get past. They will be asking for the greatest dimensions in at least a greatest dimension, optional for the other two. But when you're dealing with the frankly invasive cancers, it's a tumor thickness similar to what it would be in melanomas, even though it's nowhere near as important to have it as precise as it is in melanomas. But that's the thickness is what they want for those. It's only for the distinction of the superficially invasive from the frontally invasive that you use the depth of invasion, which is the measurement to the dermal papilla. And this little point, the remainder I think is fairly straightforward. The histology is in fact omitted talking about the glandular lesions. This checklist is more inclusive than the cervix one was, but it's unlikely to see the glandular lesions. You would not have to fill out a checklist for Paget's disease if you don't have an associated invasive with it, because the checklist is only for invasive cancers. The grading, like most squamous cell carcinomas, not all that important. Most cases are going to be moderately differentiated. The interesting thing about it is, again, they want you to also include the depth of invasion, the one to the superficial dermal papilla, as well as the thickness. But that's just a minor point. You can see that tumor border is listed there as optional, and that actually, really what they're getting at there is they don't want people to miss verrucous carcinoma. Well, verrucous carcinoma is pretty uncommon, and I think they're just basically saying if you see a lesion with a real pushing border, think about that. But for the most part, that's not what we're going to be considering here. So again, that definition of depth of invasion here going schematically and thickness schematically. So they want both. The thickness is what you would put into the into your tumor dimensions. So again, this was in the duplicate that was unintentional. The margins, essentially, where there's a gross tumor, which there will be in the vast majority of these, you will want to take the peripheral margins. You don't need to you would want to do perpendicular to the closest point. You wouldn't need to do circumferential en face. And the lymphovascular invasion, again, to be noted, and what the nodes are doing, staging. The only point I would make about the staging is that, again, the superficially invasive definition is the same as what they have here with the PT1A, but they don't have a width other than being under 2 centimeters, which certainly, if it's less than 1 millimeter, it's going to be certainly less than 2 centimeters. And then the rest of the staging is fairly straightforward, and additional pathological findings. So I think that is it. We aren't going to, as I said, talk about vagina, and so that means that we are near the end, and that's all. Thank you.
Very much, Bill. We don't have any questions posed yet, so please, I encourage anyone with questions to please go to the chat feature. But I've got one question, Bill. How would you handle where you've got a series of colposcopic biopsies and you see, early invasion, a superficial, invasive squamous, and then you get a cone biopsy, but it's all situ? Would you checklist using the combined, the colposcopic biopsies, even though it was done for the cone biopsy? How do you handle that kind of area?
Well, I have been going along more or less with what the area has been expecting, and so haven't been doing checklists even for the Leep and cone. I know that some others are, but in that circumstance, the answer would be no, even if you were, because I don't believe that the Leep cone chest is really adapted for that in the way that some other checklists are. The way you know how there are some checklists that will allow as a response no residual on definitive resection. I think since that isn't really that's been put forward, I wouldn't put the checklist. Okay.
Here, another question actually from one of our colleagues here at Grand River Hospital from Dr. Brian Cummings, not related to the checklist, but you have a question that if one has a Leep cone biopsy and there's no squamous intraepithelial lesion, but on reviewing the colposcopic biopsies, one confirms the presence of squamous intraepithelial lesion. How do you deal with that? Because we don't find that too commonly where maybe the colposcopic biopsies are therapeutic. I'm not sure, but how do you handle that kind of a scenario?
Going to too many lengths is the answer. The Leep is a largely therapeutic procedure that was to do something that when used to do cryo or laser ablation would go up in smoke. Now you have a histologic specimen, and the rationale of that histologic specimen now is to rule out invasion as rare as it may be. So that's the only really added information that you're going to get. And I think with I would not put any more tissue through. I would not do levels on that. This happens with not great frequency, but frequently enough. And if you think that what you could be missing is invasive squamous cell carcinoma, then I would also say that, well, okay, but you've got sections that are hopefully about no more than about 5 millimeters in thickness, and that hopefully are well oriented, and you haven't seen any evidence of that, I would feel fairly comfortable that you're not going to miss a clinically relevant invasive carcinoma in that.
Thanks. I have two questions, but I do remind people to please please give us their name and their location. So the first question, I don't know from where or from whom, but the question, Bill, is horizontal measurement for carcinoma of the cervix is from endocervix to ectocervix. This be smaller compared to the circumferential involvement of the quadrants.
Could you repeat that?
So horizontal measurement for carcinoma of the cervix is from the endocervix to the ectocervix. Be smaller compared to the circumferential involvement. So I think what it's implying is that you may have a slide, from the ectocervix to the endocervix margin, but it may be circumferential lesion, which may actually be of bigger length. How do you deal with that? I think the intent of the question.
I mean that the way I see this is that we're now starting to talk about lesions that are unifocal, some that they're unifocal, and probably by terms of something that you're describing there that would extend through like that should be grossly evident. And I think that perhaps one thing to say is that it is important that we or our pathologist assistants do identify lesions if they see them in Leeps, but it's certainly sounding to me like you're describing something that almost must be, frankly, invasive. And I find it unlikely that you're going to miss that by the horizontal measurement on the slide is going to be under that with something that much more substantial going the other direction. I think cases like that are probably few and far between. The first thing that you kind of start getting a sense of is if it's forming a mess. But perhaps I would say that it is true that the of all of these papers talking about these measurements only looked at it really in the two dimensions, and that there's not been good descriptions on going in the other dimension other than ones that have kind of looked at total tumor volume, which is something that kind of goes beyond what you can do. And so I think that there has to be a way of dumbing it down as much as you can to try and find something that is simplistic, and that it's that if you have any situation where you've got consecutive slides that have got the same mass in it, then you would then want to calculate to the best of your ability what the distance is between those two slides, start adding them up. But once you start seeing the same lesion, a recognizable lesion in slides from different blocks, you're probably dealing with a frankly invasive lesion. The true superficially invasive will be the multiple tongues separated usually by some distance.
Okay. We've got more questions coming in. There's actually two questions from Dr. Ramsey in Hamilton. The third question, I think, is very similar to number one. I think you may have answered it, but I will read it out. That in Leep, how do you measure the circumferential size? I think you've covered it. Is there anything additional from that question?
I don't think so, but just to emphasize again that we may underestimate grossly messes that are there. We should be look for them, because that solves a lot of problems if you can identify something that looks like a mass. And certainly short of that, anything that appears on your slide like a mass is probably going to be. But then short of that, once you start seeing things in consecutive blocks, then you're probably dealing with something substantial. But again, also there's no literature on how to assess that dimension.
A question from Dr. Ramsey from Hamilton: should the frozen section for trachelectomy specimens be en face or coned?
I am not. At UHN and Sunnybrook do the COE, and that's the way that I'm familiar with. And I don't honestly know if there are other publications from that would refute that. I'm just familiar with our way of doing it.
This question is actually from the gynae team from London. Isolated tumor cells are not mentioned in the Vulvar CAP protocol. Should sentinel lymph nodes be ultra-stage, and how should ITCs be coded?
I don't know, frankly.
Okay. I'm wondering, is that something we should maybe punt over to the College of American Pathologists committee?
Sure. I mean, I can look into that, but
we can do that, Bill. We can do that. Actually, we got Rachel Healy here who can forward that to CCO, so we can do that. So with that, Bill.
Yeah, and like I'm certainly not aware of any kind of standard of practice yet as it relates to that, but I'm not sure where it sits in the research side of things.
Okay, so we'll try and move that question forward. I have one question. As reviewing the electronic checklist through the PERT committee, when it comes to metastases, sometimes there may be a biopsy done at another time that actually represents metastatic disease, but when you're actually looking at the specimen, it's part of that specimen. Would you still log that in as a PM1, and especially if you don't have those slides to review? Because one of the issues is, taking a result from another institution that one may not have a chance to review the slides. And we find that sort of as an issue in a lot of the electronic checklists, and we're just trying to develop some sort of standardized approach to that. Another example, I guess, would be in a lung checklist where you have, let's say, a positive pleural fluid, which may be done in cytology, but when you've got the lung specimen, it may not have been done at the same time or in a different institution. So is there a scenario with the with these gynae checklists where you may have that, and what would be your recommendation on dealing with that scenario?
With these gynae checklists, I think of examples where I've been aware of metastatic disease at a time that a patient has had a sole procedure for that would be applicable to these checklists. If that situation was there, I think the inclination would be, and this is without any thought whatsoever being given to it, that since you are calling it M1, that I would prefer to do it only for cases where I can identify, say that I have got that histology in our files or in some way, or have reviewed it and can make some reference to it. I think you'd that would be my approach at this point.
Okay. So, Bill, well, there's no more questions coming through. So, on behalf of Cancer Care Ontario, the Partnership and Canadian Association of Pathologists, I'd like to thank you, Bill, for a truly comprehensive, informative, and very clear presentation today. This is our second session of the 2013 series of the CAP checklist presentations, and would welcome your comments and suggestions for ways to ensure these sessions are informative and relevant to your practice. Please include your feedback and suggestions as part of your completed online evaluations. Once WebEx recording of this presentation becomes available, it will be made available for wide distribution via links posted by CCO, CPAC, and the Canadian Association of Pathologists. Access to this recording will be available for review at your convenience and is not restricted. Reminder, both the live and recorded presentations are eligible for CME credits. To receive your continuing medical education credits for attending or viewing the educational sessions, you must complete an evaluation form for each session accessed or viewed in entirety. The link to the web-based survey has included in the session notices distributed to each session. Note the CME certificates for each of the CAP checklist education sessions will only be issued for 1 month from the presentation date. The sessions will remain available electronically for an undetermined period of time, but CME certificates will only be issued for 1 month. And again, please refer to the session notice for the exact deadline dates. So, Dr. Bill Chapman, thank you very much. And just a reminder, our next session is on Wednesday, January the 30th, and it's invasive breast cancer. And the speaker is Dr. Jean Simpson, who is Professor of Pathology at Vanderbilt University Medical Center. And she is a member of the College of American Pathology Cancer Committee and the chair for the Breast Protocol Review Panel. So we look forward to your participation in the next presentation. So to everybody, thank you very much. And again, Dr. Chapman, thank you.
Thank you.
Thank you very much.